Thanks, thanks very much, Jack. I appreciate it. It's a pleasure to be here virtually. I hope that in time I'll be able to visit you on your beautiful island there. So I wanted to, initially I was scheduled for just 20 minutes, and I think what I really wanted to do was focus on minimally invasive treatments for patients with primary and metastatic brain tumors, and that encapsulates a lot of different things, right? That is all the way from patients who have gliomas, glioblastomas, low-grade gliomas, even juvenile gliomas, all the way to patients with metastatic brain tumors or radionecrosis after treatment of metastatic brain tumors with stereotactic radiosurgery. But the idea was that as we look at different options to treat these patients, that we have an alternative that is less invasive and can expedite their return to systemic treatment in the case of metastatic brain tumors, or really, provide them with an option that's less morbid and more efficient in the case of primary tumors, while still providing cytoreduction and the ability to obtain a biopsy. I have no conflicts. This is an example, just to start out. Here is where we have a patient who's 70. She underwent radiosurgery about a year prior for non-small cell lung cancer, and she presented with paresis of the left upper and lower extremity, which had been persistent. She was basically in a wheelchair at this point, unable to ambulate. And this is a very tough lesion surgically and to treat. And when we think about our options in a scenario like this, we can possibly give her steroids to help. But the problem with her is she has hyperglycemia, and she also has a lot of bone loss. Density is pretty poor, and she has radionecrosis. Sorry, Jack.
Kalil, sorry. This time it has come up in presenter display, despite our test. Yeah, that way is perfect. Thank you.
Um, So this is a patient who, for example, has avascular necrosis of the hip, which means she's not able to undergo Avastin therapy, which would be another alternative treatment for this patient and can be effective in some cases, particularly if it's multifocal radiation necrosis or treatment effect. And so craniotomy here is going to be highly invasive for this woman. She's 70, she's not extremely robust, and she's already rather weak. This would be an aggressive surgical approach. So an alternative to this, and it's not really brand new, but it's become in some way standard of care for us, is laser interstitial thermal therapy for a tumor like this. In this situation, it is still a surgery. There is a stereotactic or an image-guided biopsy that goes on first. The patient is positioned in the operating room. They're asleep. We obtain the biopsy, and then we actually, after drilling that hole, we place a bolt into the skull, and a robotic driver is mounted on top of that. And then a laser probe is actually advanced to the tumor or into the tumor, and the patient is taken down to the MRI scan. In the MRI scanner, we actually have the capacity to turn this probe on while monitoring in real time. And so the end result of this, and I'll show this in more detail, but basically this is about a 1 centimeter incision. You obtain a biopsy, you insert the laser, you confirm its placement, the patient goes to the MRI scanner, and under image guidance, where we can see the ablation taking place, the ablation is performed, and most patients actually go home on postoperative day 1. So here's what that looks like when a patient is in the operating room. This is MR thermography. So every 6 to 9 seconds, we obtain a limited image from the MRI, which is then plugged into a proprietary software, which provides temperature data at an estimated real time. So a thermal dose equivalent is overlaid by the imaging, which gives us recoverable tissue damage, dead tissue, and then vaporized tissue, which spreads out from the laser. And nice enough that we can do that, but we can also rotate the laser all the way around and in and out with a robotic driver. So all of this can be done from the control room. The mechanism here is basically, it's simple. Heat penetrates, and at a certain heat over time, it does kill the tissue. It's kind of like if you're familiar with the concept of either pasteurization or, less eloquently, sous vide. You can either pasteurize something by having a very, very high temperature immediately at flash pasteurization, or you can do that by slowly increasing the heat over time, and that gives you effectively a derivative. And that's the way this procedure goes, is that a certain amount of heat over time provides cell death to tumors. And tumors and radiation necrosis, those cells die at a much lower temperature and time than normal brain. And so the contour actually fills out very nicely, as you'll see here. So here's a different patient. They have their probe inserted to a superficial aspect of the lesion. The probe is then advanced to the deepest portion of the lesion, and we begin our thermal monitoring. And you start to see that yellow line. And I'm not aiming the laser in a certain way, but because of the properties of the tissue that are more susceptible to thermal damage, it actually fills out as if I'm painting it. And you can see that occurs here, and that blue line continues. That's the irreversible damage. And then that growth is continued until effectively we've covered all of the lesion. We also can overlay tractography or diffusion tensor imaging. And this is kind of, and I'm hoping this video shows, but this is kind of the way it looks in the MRI scanner. I've described it, but maybe this will give a clearer picture. The laser probe is advanced with the robot, and then the thermal damage occurs from the inside out. So the overall laser time can be very short. We can only be ablating for under 30 minutes generally. Usually it's 10 minutes, sometimes even less. And the process for them is usually a couple of hours from having the biopsy done upstairs or next to the operating room and going down to the MRI scanner. So what are the applications for this? Diagnose glioma. So gliomas that are under about 3 centimeters in diameter that are deeper seated, like a thalamic glioma, that's a perfect case for this. We can obtain a biopsy and we can actually provide cytoreduction. Recurrent glioma is also great. There's always a little bit of equivalence of whether or not we're seeing treatment effect or pseudoprogression. We can obtain a biopsy and we can treat either or at the time of biopsy with laser ablation. Things that are probably the best option for this are things like radiation necrosis or treatment effect after stereotactic radiosurgery. I actually think that's our strongest indication for this. But patients can come off steroids very rapidly after this. They get home, very quickly. I will say it's important to realize that patients still have to be surgical candidates. They have to be asleep for several hours. It's not as if because they can't have surgery, they can have laser ablation, but it does decrease a lot of the problems that we have getting these patients back to treatment. So for glioma, we have to compare these patients to patients who would otherwise have a biopsy or they would have a resection. But in terms of patients who've had a biopsy only, we can certainly see that the overall survival and progression-free survival is substantial, meaning that at least we're matching the equivalence of a resection for patients who otherwise would have obtained just a biopsy. For radiation necrosis, the data on this is similarly powerful. Steroid cessation is very immediate in some cases. Patients are clinically better before their radiographic evidence shows that. So you can have a patient who's doing substantially better 4 or 5 days after laser ablation, but their MRI may take a long time to catch up and show that, kind of a classic feature of this treatment. We see that these patients have great progression-free and overall survival in some of these scenarios. So the most important thing, and I think this is really critical, and I'll show this a couple of different ways, but what I would like to show is this graph right here, is that because LIT is minimally invasive, patients don't need to come off their treatment at all. I mean, there are very few treatments which we're stopping whatsoever. I mean, the exception to that is going to be Avastin, which we try to control before and after laser a little bit, but it's still not a total contraindication depending on the scenario. The biggest thing is if they're on immunotherapy, we would love for them to stay on immunotherapy. Don't stop. And we know that the blood-brain barrier breaks down over the course of the first 7 days. It's pretty much wide open after laser. There's some lingering effect up to 21, even 28 days later of blood-brain barrier disruption. And I think what that does is that allows immune checkpoint inhibition and combinatorial therapy to really penetrate and provide these better outcomes, mostly on account of that physical opening of the barrier. So I always encourage these patients to go right back on their immunotherapy as soon as possible, even if their infusion is 2 or 3 days later. I think that really provides an excess of local control. So back to this patient here, she's 70. She has all of these reasons why she can't be on Avastin or steroids. She's rather weak. This is a deep, poorly accessible lesion. We go ahead and treat with laser. As you can see, the postoperative post-contrast scan doesn't look dramatically different at 6 weeks, but you can see the edema is dramatically resolved at that point. And she was symptomatically better probably about 4 days later, and she was able to return to ambulation. So it can be very powerful when used in the right setting. Here's a 51-year-old man who had progressive right foot weakness and difficulty ambulating. And this is a bad location to do surgery if you can avoid it at all. We know that Avastin has complications. He had a particularly troublesome ALK-positive non-small cell lung cancer where our oncologists were a little bit concerned about starting Avastin given an excess bleeding risk. Laser was a good option. You can see him here, 6-month post-op. 67-year-old man with an occipital GBM. These are his immediate pre and post-surgical films, who then had a recurrence 9 months later, right on time. And so the question was going to be, should we resect it? Should we biopsy it? Was it pseudoprogression? All of the imaging findings were a little bit equivalent. Just went ahead and biopsied it. It came back right away as tumor, recurrent tumor. And he went down and had this entire lesion ablated. So, and then he went home the following day from surgery. So these are options, and I think I mentioned the radiographically, you really have to hold with it because these lesions can vacuolate and then regress again. And so you've got to have a lot of patience to know that if you had a great ablation based on your thermographic lines, that these lesions will get better, but they won't get better radiographically. Oftentimes the patients will just get better and they're feeling fine, and you want to treat the scan and take them back and do other things. And you got to kind of hold the line a little bit as long as they're doing well clinically. But early screening is really important. These are two different cases, both of which are renal cell, actually. And these are cases where they presented initially somewhere else. They were re-irradiated. These both had radiation approximately 6 to 9 months before they had presented. They were re-irradiated in both cases. They came to me 3 months following that, a 3-month follow-up scan, and both of these lesions are not treatable anymore surgically. As you can see, this is what radiation necrosis that's out of control looks like. So, and in these cases, I can't do much at this point. So having an ability to pick up on these patients where they're symptomatic from radiation necrosis, or their lesions are just continuously getting bigger after they've been radiated for a metastatic lesion, and they grow and they grow. I've intervened earlier and earlier. If I see things heading in the wrong direction, they've had 2 scans. Maybe they're not quite symptomatic yet, but I can tell that we're going to be at a place where I either have to offer open surgery if it continues to expand, or I'm starting to get some headaches or maybe some just kind of irritation. I just go ahead and do this procedure up front at that point, because if it's an isolated lesion, you can get great local control, not a morbid procedure. And I think that, as I discussed, a lot of these things are beneficial when you've got patients who are seen in a multidisciplinary setting and you're kind of weighing the option of steroid trial, Avastin, repeat surgery, repeat radiation. It can be a great option. I will say everyone gets a steroid trial unless there's a complete contraindication. And sometimes they'll even do it twice. If the first option is not surgery, we really try and limit that. But if those patients don't proceed, single lesion, I think that in a lot of scenarios, we know Avastin doesn't change anything beside the imaging and provide a little bit of symptom relief. So if patients have a good overall prognosis, this is where we've been heading a little more recently. So I wanted to share that all with you. I'm close to 20 minutes already. I wanted to thank our outstanding team. This procedure in particular, among all procedures, is one that just takes a tremendous amount of discussion, both on our tumor boards and being able to actually do the procedure when it comes to neuroradiology being available, et cetera. And then prompt identification of these patients by our neuro-oncologists and radiation oncologists is really what facilitates a lot of this. So thank you all very much. I'll stop presenting there, and I'm happy to take any questions.
Thanks, Kalil. That was fantastic. Can I ask anybody that has a question to type it into the chat? And while we wait for those, can I ask you just one question in terms of, for our audience, do you mind, how prevalent or how widespread is this approach in the US or around the world? Are there many centers that are doing this? Or are you guys, can you give our audience a flavor of it, please?
Yeah, a good question. I would say there's probably at most major cancer centers, there's some extent of this. So probably 50 to 60 centers in the US. Obviously, we've got a lot of different, we're a large country. And I think some centers do favor it more than others. I think some of it is philosophical. To me, I think the less we do these big, giant open surgeries, the better it is for patients, particularly patients with metastatic disease, which I'm probably preaching to the choir, but the overwhelming majority of patients that we see have metastatic disease. It is the most common brain tumor that we see in general. Glioma tends to get a lot of attention. I do research in glioma. I think it's really important too, obviously. But when it comes to sheer volume and the ability to indicate a change, I think this is a great way to influence that.
And there's one question in the chat in terms of, I suppose, the mechanism of action or how this works for radiation necrosis. Can you answer that, or can you give us a hypothesis at least?
Did you mean mechanistically?
Yeah.
Yeah, I mean, radiation necrosis is highly friable tissue. So radiation necrosis cases are actually the fastest ones that I do. Is that what you meant, Bryan? Yeah.
Yes, yeah.
So those cases, if they're pure radiation necrosis, the burn time will be 3 minutes, as opposed to if it's a tumor, it'll take 15 minutes. Because that tissue is just so abnormal and atypical, and it's just dead. A lot of it is just dead, and the inflammation that we get from the radiation necrosis is the problem. And so that's why I think this ends up being the best indication for that, is just because of how effective it is. Whereas with tumors, the larger they are, the longer the burn times. And I think we're on the other side of that curve where there was maybe a little bit too much use for these bigger tumors, and you're in there for an hour and a half where you might as well do surgery. But for radiation necrosis, I think your question is a good one. It's exactly that. It's such a great target for heat-based therapy.
Okay. Super. Thanks so much. And apologies again for the switch in time, but we appreciate you accommodating us and joining. I don't see any other questions in the chat, so we can probably thank you, and we might move on to Dr. Neth. I think Dr. Abdullah is going to leave and head straight to theater. So thanks very much. So it is now my pleasure to introduce Dr. Bryan Neth, who is working currently in the Mayo Clinic in Rochester in the US. Is a neuro-oncologist who did his residency and clinical fellowships in neuro-oncology and behavioral neurology at the Mayo Clinic. And he has some very interesting and compelling research, especially in neurocognitive function, which we are very excited to hear about. So, Bryan, if you don't mind sharing your slides, and then if anyone has any questions, we'll ask you to type them into the chat. Yeah, thanks so much for joining us, Bryan.
Do you see the presenter view or the OK view?
That is now in the full view.
Yeah, very good.
Thanks.
Thank you. So I'll be discussing sort of just a background on sort of cognition, the importance in our patients with brain tumors, and then some of the stuff that we're doing at Mayo Clinic to sort of better understand cognition and ultimately improve outcomes of our patients. A lot of this work, I'll say it at the front, but a lot of this work is done in collaboration with Dr. Urs Schenner, who's one of my colleagues, and we started some of this when I was still in training. All right, so I have no disclosures. The big points, the access to specialized neuro-oncology care is limited in the US and throughout the world. Like in the US, for instance, there's 315, 320 like neuro-oncologists in the whole country. It's a very, very, very small field. And we know that patients who receive subspecialty care to doctors who are obviously taking care of patients with brain tumors on a daily basis have better outcomes with longevity as well as quality of life. And decentralized care supported by digital tools, which I'll discuss today, allows for subspecialty care as well as future research opportunities. And then if we have time, I'll talk about some potential applications to the non-brain tumor world, so breast, prostate, lung cancers. So cognition in patients with brain tumors. So it depends on your study, but greater than 90% of patients with brain tumors, particularly if they have certain treatments like radiation, will have some level of cognitive impairment in at least one domain. So most common is memory, but you can have difficulties with attention, executive function, processing speed, visual spatial, depending on parts of the brain. And importantly, there is, patients will have some level of cognitive impairment even prior to treatment. I created this schematic sort of showing that it's important to understand the tumors that we see. So we see a lot of meningiomas, brain metastasis, and Mayo and Rochester were glioma heavy, glioblastoma, and all low-grade gliomas. But sort of there's a big difference based on tumor type and location. So here's like a convexity meningioma, might not have any symptoms, be 5-7 centimeters, quite big, not have much problem for years. However, if you have skull-based tumors that are affecting some of the optic pathways or some of the cranial nerves or brainstem function, it's a different tumor, even though biologically it's the same. Brain metastasis, you can have a few solitary, brain mets, do the gamma knife or stereotactic radiosurgery, and do quite well. But if you have large tumors, particularly if they're in sort of some of the language speech areas or innumerable tumors, it sort of changes the game rather than just a few solitary mets. And then the glioma is different. So you can have a lower grade glioma, like a oligodendroglioma, and we have patients that can live 20 plus years routinely, versus the glioblastoma, which might show up as a small area, but we know based on biology that it's actually really throughout the brain, even if it's on imaging not showing up. And then there's a big heterogeneity to sort of the biology. And with evolving of cancer neuroscience, particularly in glioma, as well as more in brain metastasis, we know that a lot of brain tumors actually integrate with sort of normal brain pathways and signaling. And it's a very exciting time to be in this field. So, why, what's the basis sort of for cognition? Big thing, as we said, is type and tumor location. Location's huge, but it's also therapy. So surgery, a big literature is focused on radiation, as well as some of our systemic therapies, including Avastin, which was previously discussed, potentially could have some variable effects on cognition. And then it's everything else. So, if someone's 80 years old versus 20 years old, they might already have some early memory loss or something like that. There's a lot of comorbidities, epilepsy, a lot of patients have, depression, fatigue, sleep disruption, and other, what if they have cardiovascular disease and cerebrovascular disease, have already had strokes prior to having a brain tumor. There's many, many factors that sort of go into it. But certainly because of being a tumor of the brain, it's the type, location, and treatment. So why is it important? So there's many studies that have shown that it affects quality of life and functioning, return to work status, and potentially also can affect how long people live. So this is a study from using some of the Mayo data and MD Anderson data from 2012, and this is Kaplan-Meier plots showing the number of domains that would be impaired in specific tests. So here's the test down here. So patients who had with glioblastoma that had no cognitive impairment on the 4 domains, lived longer than patients that had only 1 domain or 2 or more domains impaired. This has been shown in multiple studies. And obviously, if it could suggest that, hey, there's more tumor there, or it could suggest that a patient who's 80 who has poor performance status might not be going to get the full treatment that other patients would get. So how is it assessed? So cognition and thinking memory is quite variable. So I've just completed a large review on like systemic malignancies and cognitive assessment. But in the brain tumor world, it's variable. So most commonly, it'll be before and after surgery, as well as after that initial radiation, and then it sort of gets more gray into longer term. So is it every 3 or 6 months? Is it every year? It depends quite broadly on the institution and sort of what is done in norms, or what is normally done at an institution. Additionally, in research trials, so a lot of our data from cognition actually comes from clinical trials, and it's quite variable even there. So some trials will have formal neuropsych testing. It might go up to 3 or 6 months after the study's done. Some will just do self-report measures. So formal neuropsych can routinely done. So if it's doing a full sort of Alzheimer's type assessment, it can last for 4 hours. But you can get a battery, done within 2 or 4 hours. I just put some of the most common tests that are done, mainly looking at memory, executive function, processing speed. Those are big domains that are assessed, and then you have some more global measures. And then we also incorporate self-report measures. So we use this one, the ORTC. PROMIS is used quite a bit, and the FACT-COG are used. And again, the biggest theme is the variability and the cost associated with this. And additionally, although it's patients with brain tumors often have cognitive impairment, we don't have many therapies. So the medications that we use most in our clinic is methylphenidate or Ritalin, so stimulant type medications, which have shown some benefit in older studies. But it's not everyone will respond, so it's a little bit of a trial and error. And we don't give it to everyone. So if someone has poor performance status and isn't going to really be engaged, much in their work or world, we don't just give them methylphenidate. It's more of patients that are sort of right on the edge of returning to work or not, and we think we can kind of boost them up a little bit with the fatigue and sort of attention aspects of the med. There's good data in whole brain radiation that Namenda or memantine works. So that's used in patients routinely getting high doses of radiation or radiation that needs to go to some of the memory centers. But again, it offers fairly modest benefit. Sometimes off-label we'll use that. Donepezil, the acetylcholinesterase inhibitor, Alzheimer's med is also utilized, sometimes off-label. But really, it's physical activity, health promotion, cognitive stimulation, brain training are sort of the therapies we have. We don't have any other targeted sort of medical therapies, which is, so as a neuro-oncologist, is important because a lot of my patients have significant fatigue, sleep disruption. There's a motivation. They don't really have the drive to kind of get up and do exercise and other, be physically active, which is important. So the big challenges are time and resources. So, the time to do a formal neuropsych testing every 3 or 6 months, indefinitely is quite important, as well as in the U.S. Like insurance doesn't cover after that first or second neuropsych assessment. There's limited subspecialty expertise, or some of the neuropsychologists might be focused more on the epilepsy side or the Alzheimer's dementia side. And then, some people say, hey, why do you even study it if we don't have therapies to know? So we know that people have cognitive impairment. What are you going to do with that information? So I'll talk a little bit now about our approach. So again, Dr. Schenner is the PI of this Neuro-Oncology Anywhere study that I'll talk about, but I helped him design this when I was finishing up fellowship. So our first clinical trial, our decentralized clinical trial, sort of allows us to do most of the care through video visits. And I'll talk about the specific components of it, but we call it Neuro-Oncology Anywhere. I call it Neuro-Oncology Metformin Trial. So we take patients who are within 5 years of receiving brain radiation, and our goal is to assess cognitive outcomes with two main groups. So everyone gets a wearable device, sort of like a Fitbit-like device, to promote physical activity engagement, because we know that is important for brain health and cognition. And then half the participants receive metformin, which as we know, is a medicine for diabetes, but there is some good basic literature supporting its use in some of the anti-inflammatory pathways that we think are related to the long-term effects of radiation. So part of this, we have some basic assessments. So, in patients, particularly if they're sort of mentioning, hey, I have some memory thinking concerns, as long as they're 3 months post-radiation and within 5 years of radiation, anyone with a brain tumor can enroll. And part of the initial assessment, we do a basic neuro exam. We do something called the short test of mental status, which is our like MMSE test that we do at Mayo. And then some basic screening labs. So once patients enroll, every 3 months, for a year. They receive video visits. So like we do Zoom visits clinically, and we do an abbreviated neurologic assessment. We do the thinking test, so the STMS, and then we do a digital thinking test, and then patients are doing surveys. So it's pretty low effort for the study enrollment on patients' behalf, but it's a way that we can reach people really anywhere in the world as long as there's an internet connection for the trial. So the primary outcomes of the study is to look at feasibility and acceptance of this approach, because when we designed this 2022, 2023, it was still sort of right outside of the pandemic time. And there weren't a lot of studies like this. So we're just looking at feasibility, as well as can our participants completing all the specific measures that we have. So the digital thinking tests, the neuro examinations, some of the questionnaires that we have, as well as logging that they're taking the metformin if they're doing so. And secondary, which we'll hopefully report at the upcoming Neuro-Oncology SNO Neuro-Oncology meeting, is looking at some of the early outcome data specifically for the impact of metformin or physical activity on cognitive outcomes. So again, big decentralized components that I discussed, and I'll share screenshots of this, but we call Mayo Test Drive, which is a memory test and a symbols test. The wearable activity device, which we're going to incorporate into a lot of future studies, but looking at sort of basic step counts, heart rate variability, sleep quality and duration, those types of measures. Remote neuro assessment, NANO, which is widely used mainly in clinical trials, adverse events and quality of life assessment. Importantly, the medication, so metformin is delivered by a mail pharmacy. So again, the more of a decentralized component. And then patients have the opportunity to get blood draws in home, but a lot of them will just go to sort of their local center. They don't have to come to into the city to get those done. This is a snapshot of the Mayo Test Drive. So this was developed by Dr. Stricker and another Dr. Stricker, and used primarily in the Alzheimer's dementia world at Mayo Clinic, so in behavioral neurology. And this includes like a memory type test as well as a widely available symbols test. And it can be, it's web-based, so it can be used on any device that has access to the internet. So smartphones, little screenshots here, but also it can be utilized on a tablet or a computer, which is nice. Patients are essentially through the electronic medical record are sent a link which is a unique identifier to them, which is with a specific time point that then sort of gets logged into a central database. But as long as they have an internet connection, they can do this. The test takes around 15 minutes or so to complete. Ideally, these are performed prior to specific study visits or a specific clinical visit. And it's adaptive. So particularly the Strickler learning span, if patients are doing better on a test, so they might get a span of, remember 10 of the words on the memory test, it can make it harder. Okay. Or if they're not doing as well, it sort of adapts to where they are. So, this doesn't assess every cognitive domain, but, importantly, it assesses multiple of the limitations that we currently have. It's an objective measure that's been validated, primarily in the aging world. We're validating it right now in patients with brain tumors. It's something that we can follow serially over time. When you have sort of the adaptive measure that sort of changes with how people are performing, it can sort of take out a little bit of a learning effect, from standard tests as well. And it's something that's, pretty affordable after this was developed. It's pretty affordable to sustain. We're not taking, time for certain staff to do this other than our time to kind of review results. So this is something that we're utilizing and hope to get in the clinic soon, not just in clinical trials. So this is just a recent paper that the group with Dr. Stricker sort of published looking at our aging cohort at Mayo Clinic, sort of validating it on a larger cohort of patients. So essentially, patients are completing these tests early. So the first time you get it, you complete it early, but then long term it might sort of drop off a little bit. So the sustainability aspect of it, but It is usable even by patients that are in their 70s, 80s, and older, based on the aging cohort. So again, I kind of briefly mentioned this, but this is just sort of snapshots of the nano. So nano, neurologic assessment and neuro-oncology examination. So we do this routinely. So any neurologist say, gait and walking is probably one of the best measures that you can look at. But we get everything except for visual fields and sensation on like a neuro exam. So you can look at eye movements, you can look at facial symmetry, you can do drift. You can look at alternating motion rate, ataxia, walking, the sensation, other than saying, okay, does your right side feel like your left side? You can't, we're not typically sort of, having like a care partner sort of do sensory exam, but we get a modified nano. Um, the short test again is just like a standard, broad assessment, like a MMSE or a MoCA test that we utilize, and we could do this whole component, digitally, so it's all sort of verbal, and then we just show them a cube, and then everything else is able to be scored, and then any wearable activity device. We're currently using a Fitbit type device, but using like an Apple Watch, which has even more functionality with recording specific medication adherence as well, is something that we're looking into. This is our current battery that we're using. We are looking to add more to the digital test. Okay, so the test drive, sort of adding more assessment of executive function. We're looking at sort of digitizing this short test, okay, or like a MMSE, so we can send them patients a link, prior to completing it. So it's taking those 10 minutes that we're doing in clinic that we could already have it done sort of automatically. And then, longer term, be developing a way to sort of, video patients completing a very brief neurologic battery that we could sort of learn from even prior to coming in to seeing a patient, sort of gathering all the information prior to quick visits. So here's some preliminary results from the study. So we had 100 patients planned. So this data as current as of January of this year, but the study started enrollment May 31st last year. So even before a year of enrollment, we've already had over half the participants. 51 participants were on trial, 3 withdrew after being on. Looking at some of the basic sort of completion. So the patients who received metformin, they're logging their dose, whether they took it or not, at, about 80%, which is what our goal. Importantly, the test drive, which, this is the first study looking at this sort of digital tool that, our digital tool in patients with brain tumors. It was the completion rate, and most of these were baseline completion rates. There was a few that were at that 3-month mark by this point, is 98%. And you can see that the average duration is about 16 minutes. And most participants are actually completing it on their smartphone and then at home. Some of them would do it right in the office when you're seeing them for, other brain tumor care. Completion rate of surveys is 85%. Completion rate of sort of doing the Kochman or the STMS and our neuro exam, the nano exam, is 95%. So this is in the context of a decentralized clinical trial, right? Where we have a study coordinator that's helping this, tell patients, hey, complete this, complete this. We tell them complete this. But we don't, this is not something that we're currently doing in clinic yet, but we are very hopeful to do so. So this is sort of where we want to go. So by the end of 2025, our goal is to get all these measures that we're using right now in test and actually just start routinely getting them in patients with new brain tumor diagnosis. So post-op, post-radiation, and then every 3 to 6 months after that, just routinely assessing. So, we can do frequent reminders, automated reminders through our medical record system. But, so the hit rates I would expect would be lower than if we're doing a clinical trial, but it's just a way that even if we're getting 60% completion rate, that's better than essentially the 0% that we're getting right now with longitudinal assessment. And part of this, we understand we have historical data. So once we have further treatment trials in, then we kind of know what patients' trajectories are. We understand sort of the natural history of a low-grade glioma, sort of cognition, and it's something that's can be done anywhere, as long as patients have internet connection. future trials. We're looking at metformin now, but there's many different potential trials, largely locused, in brain tumor world is largely focused on neuroprotection from radiation, including some of the vascular sequelae. There's big interest in targeting inflammation. There's a lot of sustained microglial activation, which could be a potential target. Obviously exercise and cognitive stimulation, those have been shown to be beneficial. And our group is mainly going to be looking at medications to sort of supplement some of the physical activity and cognitive stim aspects. So again, key points, the big thing is being able to utilize video visits, being able to utilize digital tools to take care of patients with specific expertise is important for outcomes, but also is something that we think in the future will be much more widely adopted as part of routine standard clinical practice, but also in research trials. And that's that. I have a lot of people to thank, but Ur Schenner, Dr. Haddad, Graf Radford, these are all our study coordinators and decentralized team, Taylor and Sue and Heather, and big team here that has helped with the trial. And
that's fantastic. Thanks, Bryan, for sharing your insights and the what's such an interesting study, because it all these tests, as you say, take so much time, but adapting them or digitalizing them and having them completed before clinic or with remote assessments is something we should be moving towards in our routine practice, if it's safe and if it's functionally beneficial for all involved. It's beneficial for our patients to be completing these at home and beneficial for our clinics, right? If, a lot of the assessments are done before the patients arrive. So from our audience, if there are any questions, if you want to either type them into the chat function or if anyone wants to raise their hand. I suppose while we wait for any, in terms of challenges with these digital assessments or assessments that you've come across, can you give us any insights there or any places this has fallen down or from your own practice?
Yes. So I think we'd run into more challenges, I think, when it's routine clinical practice, because we don't, our big benefit is the study coordinator who sort of can continue, knows who's taking it or not, and are doing the surveys, doing the tests, and actually bug patients a little bit, say, hey, can you complete these? We send reminders. I think the biggest challenge is, particularly if patients who have temporal tumors or have memory problems, they actually aren't, might actually forget to do these tests. Certain, frankly, younger men patients are less likely to sort of just do this without sort of prompting, is what I've noticed in our first go round. But most patients, so there's a comment section after every sort of, particularly that digital test, the Mayo test drive, that patients sort of say, oh, yes, I like the challenge, or say, oh, I enjoy the platform. So I think because it's web-based and sort of can be accessed anywhere with an internet connection, a lot of patients enjoy the platform, and they're used to sitting there scrolling on their phones all day anyways. So it's a way for them to do, it's not a brain training game, but it has that sort of feel to it where it's engaging enough, and it's short, 10, 15 minutes of their time. Particularly if it's been validated in an older patient population. So like our Mayo Clinic study of aging, the average age is like 70 or so. If it's been validated in older patients who might be less, comfortable with some of the technology, then, in our patients, most patients do pretty well with it.
Great. And it seems extremely patient friendly. We have two questions in the chat. One from Professor Connolly commenting on how great a study this is in your presentation, but asking about the role of the patient versus the family enabling these projects, because obviously GBM is a high-grade glioma or low-grade glioma. They're very specific populations. What what are your thoughts, I suppose, or or what have you seen with the patient versus the family members getting involved or engaged in these projects?
I think most patients are excited about when we talk about memory and thinking. And first, you talk about my background, but I did neuro-onc and then behavioral neurology, which is pretty much Alzheimer's here. Um, and so I went into it with that perspective, saying, okay, I'm going to start doing sort of like memory tests on everyone, sort of in my patients. I'm just going to start doing them. And that, the burden of that 10 minutes, 10 minutes to do a little sort of screening test every visit is high for someone even that's super motivated to do it. But when you talk to patients, what we kind of show them an MRI as you do, and you say, okay, the tumor's growing or not growing. Patients are consumed, with that as rightly could they should be, right? And what are we can do for treatments and such. But most people sort of it's not dismiss, but it's sort of the mood, the fatigue, the sleep, the memory, all that takes a back burner. So if you have anyone who's interested in it, or any of our team that says, okay, hey, are you interested in this supportive care trial, right? Most patients have been at least interested to sit down with our study coordinator and say, yes, let's do this. And that's why, the accrual started with, within 9 months of opening study, we're already over 50 patients in. And also the burden is low on them, right? Doing a video visit, which is routines. So the time commitment to them is, 30 minutes essentially in every 3 months. Patients. So I certainly have had patients anecdotally that might not realize they have a problem, so or don't really care, but then like the loved one is like, yeah, you should do this, and then they'll do it. One issue, sort of particularly with the digital memory tests that we have to sort of think about, and we've been thinking about, is when you do a digital memory test, or anything that, I'm not sitting there watching you do it or administering it, there's always risk that, particularly in a study context, that the caregivers, will sort of step in and do the test for them. And we've seen in the Alzheimer's world, we saw discrepancies. So we do the full sort of HVLT, and then we do the stricter learning strand, and they do very, very well on that. And then they do poorly on the in paper test because, for various reasons, but they might not have done it. So it's because patients really they want to present their best selves to you and think that it's looking okay. But I think most patients and their caregivers have a lot of buy-in, just because they want people to do better with their thinking memory. And even some providers won't even do Ritalin or methylphenidate, just because in the U.S. it's a controlled substance and such. And we having particularly trial opportunities to get patients new treatments, everyone's excited about that.
And are there built just on that before I ask the second question, are there built-in time or reflex timings within the apps or within the digitalized tools to assess, for example, how long it takes a patient to answer a question?
Mm-hmm.
There's a lot of those kind of subtle learnings from digital tools that are possible. Are they built into the Mayo test drive as well,
It
or
is.
yeah?
Yeah, the latency and duration of each test, and that's something as well. So even doing like a simple trails test, you can incorporate that into a digital trails test where you're getting screen strokes and stuff like that. That's very, very important, especially in our brain tumor patients, all post treatment, especially.
Super. And then our colleagues in Waterford have dialed in, and they were asking about whether there's a specific exercise program prescribed, or do they wear the tracker as a motivation?
Yeah, so for our study, it's health promotion. So they enroll, we bring them a Fitbit device and say, okay, we want you to exercise. At each visit, we are sort of saying, yes, how much are you exercising, and you need to kind of keep it up. And we have patients that'll say, oh, I'm walking 10,000 steps a day or 15,000 steps a day. They just go around the stores and just walk, in our winters. But it's variable. Some and you see that as well in any clinic, right? Motivating patients to exercise and patients who wouldn't have exercised is variable. But if you tell them, by far the best activity for brain health, whether you're trying to help prevent, dementia and Alzheimer's, or post-stroke recovery, post-TBI recovery, brain tumor cognition. Exercise is the best thing. So I always tell patients, you find something you enjoy doing. If you're not doing any of it, do 5 minutes a day and then work your way up to 30 minutes a day. Give them achievable goals. But it's something that it's more passive on our end. It's really the device is sort of saying, oh, it's a fancy device to hopefully, get them interested.
I think it's great. Any kind of reminders or any kind of things to reiterate what we say in clinic about exercise, when they're at home is positive, and will hopefully lead to better patient outcomes in the long run. That's great. I don't see any other questions in the chat. So I think with that, we can probably kind of wrap up a little bit. Bryan, thank you so much for your time. For everybody else on the call, our final session of this year's Cancer Seminar Series is the next presentation, which will be due. It's Monday, May the 12th at 1 o'clock, which will be Dr. Breffney Hannon and Andy Phillips. So the registration link will be sent around for that. Thank you again to our speakers, Dr. Kalil Abdullah and Dr. Bryan Neth, for joining, and we'll wrap it up there. Great.
Thank you.
Thanks, everyone.